Zone 3 Podcast. I am Robert.
Yes, and I am Reggie.
And today we're joined by the Godfather. I'm talking about you, Bill.
You, Bill. That's you. That's you.
And you brought Nancy with you today. So
Good
if you will,
morning.
we'll start with ladies first. Nancy, just introduce yourself.
Hi. I'm Nancy Hill Beluk. I go by Hill because that's how most people knew me for the good 40 years of my life in MR until I got married and took his name. So I'm at the University of Pittsburgh. I've been an MR tech for as long as DIRT has been around. I think that's about 42 years. Yeah, that's how long DIRT has been around. And currently I work in the Pediatric Imaging Research Center and do pediatric imaging.
Very cool. And so you're from Pittsburgh originally then?
From Pittsburgh. Yes.
Is
don't
that where
take that.
Canal is at?
Yes. Yes. And a little known fact, I started out at the NMR Institute of America, which was in Pittsburgh. And my fellow was a gentleman by the name of Manny Canal. So, yes.
Sounds familiar. Rings.
I know. There's a couple names that we throw out, and that is one of them. And,
That's a good one.
Yeah. So I have known Manny since he had only 2 children, and I think he has a whole football team now.
He's got a herd.
He has a herd. He has a herd. So, who are now, one is a radiologist. So,
Really?
Big
How cool is
shout
that? Yeah.
yeah. So, yes.
And I think he's only like a couple, 3 years younger than me, actually.
Really?
Yeah, he's not.
You-
he just.
Can we say that on air?
Well,
Sorry, man.
He's aged better than I have.
Okay. Okay. So
Well, he
that's
gets up and works out before every one of those seminars, I know, right?
Oh, well, we were talking earlier this morning. He loves hot weather, and when he does a course in Vegas, he always wants to do it in July because he's just cold natured and he likes to get out and run in 100-degree weather.
I can appreciate that. You get out, it's good. It's detoxing.
I can't.
Well, Bill, I think everybody knows you, but just remind them real quick. So you are from?
I am from Chattanooga, Tennessee. Have lived there my entire life. Very fortunate. Actually trained X-ray training at the hospital that I was born at.
Oh, I didn't know that.
Yeah,
That's cool.
And back in the 1970s,
Yeah, what was your MRN number?
Two. So I've been doing MRI since 1985. We started the first imaging center with MRI in Chattanooga.
Yeah.
We had a GE 1.5, and back then 1.5 was a big deal. I mean, it was scary, and I think our
we
serial,
thought we were cool.
I know. I think our serial number, if I remember correctly, was like 76.
Ooh.
So it was really, and that's how I eventually met Nancy. She was working at another facility and doing a project where they were trying to put together a MRI simulator using the early Mac computers with a program called HyperCard.
Really?
And we were
It's on a floppy.
acquiring different images at different TRs and different TEs, and they were going to put it in there so you could dial it up and see what the image would look like in the early days of MR, because you didn't really have anything to train from. I mean, all we had was spin echo.
Right.
And if the doctor wanted a spin echo, they're going to get a spin echo. Otherwise, they'll get a spin echo.
Right.
So you guys have known each other from the start of your careers then, pretty much.
Pretty
Yeah.
much.
Yeah.
You got
Pretty
some
much.
dirt on each other, I would imagine.
Oh, yeah.
Oh, yes. I know we both went to the same story and went,
oh, yeah.
no.
Well, I feel like we do got to get a shout out to Kristen because Kristen is not feeling well. And she was
Yeah.
going to be here because we're talking about pediatric imaging today.
Yes.
And it sounds like you guys both have a lot of history with that, a lot of experience.
And before we kind of jump into that, of course, love to give a shout out to our sponsor today, who's sponsoring the episode. Of course, NEATCap Medical. Big shout out there.
Appreciate it.
Yes.
Thank you.
There'll be more on that later in the episode, so stay tuned.
All right, throwing out little teasers. I like
That's
it.
right.
He does
So
that.
I think a great place to start as far as pediatric imaging is like, first of all, what's the differences between that, like considerations and adult imaging?
Well, when I had a real job and managing imaging center or the MRI business at Erlanger Medical Center in Chattanooga, we had a pediatric day where we would do pediatrics because of the way we'll talk about sedation later, but because of the way they do it. But anyway, I think today the major considerations are when you've got an adult, a lot of our protocols are real sloppy. By sloppy, I mean they're overweighted. They got too much in them. Throughput today is not a matter of how fast each scan is. It's how many stupid, useless series you do. And so for the most part, in a lot of facilities, they don't have tailored protocols per se. I mean, you may have a stroke protocol or something, breast protocol, stuff like that. But I mean, just in general imaging, you don't tend to have it. You just do everything you can think of.
Yeah.
And I think in pediatrics, you really can't do that. In pediatrics, because of the time involved in it, the protocol has to be tailored to answer the clinical question. The other thing is you have time constraints, whether you're doing anesthesia, heavy sedation, feed and bundle, we'll talk about that, or just cold turkey for a kid. They're not real patient. And so holding still for 5 minutes, 4 minutes can be very difficult. We have a lot of exquisite scan acceleration techniques today, compressed sensing, the artificial intelligence reconstruction algorithms. We have great motion reduction techniques, propeller, blade, multivane jet, whatever, all the different names of them. And I think people need to take a serious look at their protocols and tailor it for motion reduction, speed, and effectiveness. And to me, that's the biggest difference. Coil selection is a big thing, but with today, there's a lot of flex coils. A lot of companies have those flex coils, and I think that's excellent for pediatrics. That's where we were lacking for a long time, is in coils.
Right.
I don't know what.
Well, the other thing I would say about the term pediatrics, it can be very confusing because it's from birth. It can go up to 17, 18, and we were discussing it, some places can go up to 21. So to have a pediatric protocol isn't like an adult. It's not a one-size-fits-all. So I've seen, sites that will have protocols for 0 to 4 months of age.
Yeah.
They grow so quickly, in blink of an eye, as we say about my grandson. So 0 to 4 months, and then, up to 24 months. And, the other thing you have to consider is if a child's born preterm, gestationally, they're not at the 2 month, or they may appear to be 4 months when they're really smaller. So there's a lot of more processing that needs to be done when you're looking at these protocols. And it's not just fields of views and slice thicknesses,
so
things
that's
like
kind
that.
of the easy stuff. You think small, but then
Right.
that's where your coil technology has to come into play. But you have to think pulse sequence and parameters, because their tissues are not the same, especially in the brain.
Yep.
Going in the early years, gray and white differentiation, myelinations. I don't know. I always heard it was myelination wasn't really complete to maybe like 5 years of age or something.
And
like
for you, it was about 24
Oh,
maturation?
yeah, I'll let you
Okay.
actually.
All right.
No,
I'm sorry.
You're thinking
Post that.
frontal lobe
Yeah. All right, I had to get that one in.
which is kind of gone away
right.
now, actually.
Right. Right. And
No
and
reasoning.
right.
Well,
and
I have no frontal lobe filter.
right. And I'm not saying children don't have necks, right? But they have brown fat, and their fat is distributed differently. So the coils that fit for an adult, for a head coil, you're assuming they have a neck, the head can go in. But this, you have to jam up the whole shoulders and everything. So it's kind of like and I'm not calling your child a pug, but a pug compared to a golden retriever, right? I mean,
Right.
it's, how the fat, how the brain, how the facial features are distributed are very different.
Well,
are very
I'd
different.
like to tell me that again, because you mentioned the different types, different kinds of fat: brown fat, white fat.
Brown
And
fat,
I
white
had never,
fat.
and I had never really heard that before. But I know a lot of times, people have complained, like fat saturation on kids.
Right.
Very difficult, but the frequency must be different. And I'm
Right.
sure the makeup is.
Right. So, the baby pudgy neck, that's brown fat, and that all goes into the thermal regulation considerations that have to happen and when you're swaddling. So, yeah, I mean, it's a different material. It gets replaced. I could keep going on picking on Bill, as you asked, but I won't. But these are all things that need to be considered. And so when you have a scanner that only does one pediatric a week or a month, it's a lot to be thrown at a technologist, radiographer, to kind of turn your brain off and go to the other side. So, yeah.
And I think that's where the protocol bloat can really come into play, because if you don't do them that often,
Right.
then there's a tendency to throw every sequence you've got on the scanner at it,
Right.
because you really don't know what's going
Right.
to work.
Spaghetti on the wall.
Right,
Something will
right.
stick.
there's another brought something to mind there. One of the things is vascular imaging when you're doing pediatrics. Okay, contrast enhanced angio. You're given I don't want to get too much in this. Is almost a podcast in and of itself, but you're giving such a small volume of gadolinium that in many cases it needs to be augmented with saline in the gadolinium syringe. And a lot of people call this dilution, but it's not really diluting it. It's augmenting the volume.
Right.
Because you're going to give X amount of GAD. Now, whether you gave that GAD with 10 cc's of saline or not, you're still giving the same amount of gadolinium molecules. So you're going to get the same effect. Right. It's just more for the volume delivery over time. So there's that consideration. And a lot of people try to keep their volume the same. That way your timing is similar.
Wow.
Then you also should consider using some of the time resolve techniques, which work really well in pediatrics because that takes the timing issue out of it. And you also get away with a lower volume of gadolinium with those short, time resolve twists. Tricks.
Yeah.
Oh,
whatever,
I know. Right?
I thought you were
Did
dancing.
you say
I-
tweets?
whatever you call them. Anyway, so I think there's a whole slew of protocol things that have to be considered. And, then we'll talk about some safety issues and stuff like that.
Do you know if gadopictinol has been kind of FDA approved for pediatrics yet?
I want to say it's got labeling 2 years. I believe it's got pediatric
Up to 2
labeling.
years.
I
Okay.
believe it does.
Yeah,
we'll have
we'll
to
fact check that.
Yeah, fact check me there.
We'll put a big red lamp.
But I know that's been a big drawing point for a lot of radiologists I've talked to is the ability to actually give a smaller amount of gadolinium,
Right.
actually less gadolinium,
Right.
particularly in a population more vulnerable and it's going to get repeated over time.
Right.
And the ability to cut back the dose and stuff like that, even from that. So,
For sure.
but again, off-label use is really just kind of a non-issue anyway.
Right.
But
Right.
I know a lot of facilities, they have kind of like a minimum, and that's usually per rad request. They have like a minimum dosage. It doesn't matter if the patient weighs, say, 35 kilos, we're still giving a minimum 5, like of Gadavis or something. So like,
yeah, I wouldn't recommend that. That's overdosing. I mean, that's just that's I think you do weight-based dosing, and if you need to augment the volume for injection, you just put some saline in with it.
So if you're doing like a neonatal that weighs, like premature baby that weighs like 2-3 pounds,
You're just going to give a very small amount of gadolinium,
Dose
but you got to
accordingly,
get it
yeah.
through the tubing and that sort of thing. So it's just augment it with saline.
have you ever started an IV on a?
No, we
That's
are
what
blessed.
nurses are for.
Yeah.
Right.
I didn't want to say that. I was going to say we were blessed to have a pretty crack team who
Yeah.
do this.
And
all day
then
long.
like, what's the? I mean, this is just kind of a side thought, but like, what's the gauge that they would use? Like, are we able to inject at a certain rate for these sort of like time resolved sequences?
Well, you really don't have to inject at a very high rate, quite honestly. I mean, some people think you got to inject like 2 mL a second.
you don't get like venous artifact.
Well, I
or-
mean, no, you can just, you inject it in at like 1 mL a second. That's actually another way to make it last longer is you just slow it down. And, you've just got to get your timing correct with it.
that comes with experience, I would imagine.
Yeah, it does. And it, that again, going back to Nancy's point, if you don't do very many pediatrics, that's why this stuff is generally not well done,
Right.
And so I think again, planning. You really got to talk this out and plan how you're gonna do it.
Part of the planning, like you said, are tailored protocols, right? And so that's usually with consultation with the rad, right? I mean, based on the pathology and the reason for the exam.
Yeah, and again, to Nancy's point, you got to consider the age of the patient.
Right. And, we were discussing this earlier. When you're looking for hydrocephalus, you don't know it's there on a baby. When you're following up with hydrocephalus, you know it's there. You can tailor it. So those situations, you need to have the full gamut of information, the full gamut of sequences to define that. And we're also finding from the emergency room, they don't want to put a child in a CAT scan. They don't want the unnecessary radiation. So we have these fast scans. And it's not necessarily that they're fast sequences. They are. But it's just a real quick snapshot of what's going on. And that doesn't exclude them doing further MR imaging. It's just so that they know what then when they bring the child back or if the child's admitted, what specific sequence is.
And
They
I'm
can
trying
do
to
so-
remember.
But you don't do that in
Right.
adult imaging.
Right. Well, see, and I'm thinking of it, the hydrocephalus thing, and mentioning a protocol. A good friend of mine who's now retired, Dr. Howard Raleigh, we used to do a lot of talks and stuff with Howard, and he would always talk about he had a very shortened shunt, check protocol, which is basically three planes, single shot fast spin echo, and out the door, because it gives you the answers that you need. And to Nancy's point, then you don't have to do a CT on the kid.
He's a Wisconsin boy.
He
Right.
was
Is
in
he
Wisconsin.
the-
I think he's moved out to California
Is he the
now.
pig guy that
He
does?
was a pig farmer.
Okay.
He was a pig farmer. Yeah.
Yeah, pig farmer sounds better than
I should call
pig
him
guy.
the pig farmer, not the pig guy.
Yes. Again, let's
shout
put
out.
that. Yeah, let's put that.
Well,
Right.
disclaimer: I have not actually done any pediatric imaging personally in probably about 5 years. But when I did, I remember it was a lot of single shots. I remember we would reach out to the radiologist before. I remember the patient, the baby, would come down, and I say baby, but at the end of the day, like pediatric imaging goes up to what age?
Well,
Like if you were to define it.
teenagers,
Like
Yeah.
is a 17-year-old considered?
in
Yes.
most places, yes.
In most
Okay.
places, yes.
And not every place will do pediatric imaging with contrast because maybe they don't have a code card for it, or these are also considerations, right?
Well, you should always, regardless of scenario, you should always be ready to treat an adverse event,
Yeah.
right? In some fashion. You should also ensure that at your facility you can rapidly, safely remove a patient from the MRI environment to treat them. And if you think about it, if you're doing a very complicated pediatric exam, either under deep sedation or general anesthesia,
Easy, right?
you're going to have to
Right.
know, everybody's going to have to know what they're doing.
Yeah.
Right.
Oh,
Right.
Right.
But back to like the duration of these sequences, because you say fast scans, right, or fast protocols. That's kind of open to interpretation. It's all relative. So, what is like, in your experience, what is a fast scan? What is
like abbreviated is what you kind of meant, right?
like time wise though? Are we talking 5 minutes for a
Yes.
full protocol?
Well, for an abbreviated protocol, so that we can have a definition of what's going on in the child, so we know what to scan when we do a full MRI. So,
Yeah.
And
So
it's
it's kind
funny.
of like a baseline at first.
Perfect answer. Yes, and
Okay.
and so it can get very confusing when we use these terms like fast scan, because they want it to be a shortened sequence or a shortened protocol. So a fast protocol is not necessary anyway.
Right.
We use the same word twice in a sentence.
Yeah, you
and-
could have a so-called fast protocol or abbreviated protocol, but might have several scans sequences that are 2 or 3 minutes apiece, but you're not doing a buttload of sequences. Or,
Right.
by the same token, you can have sequences now that you try not to get any sequence over 2 minutes using artificial intelligence or using some sort of scan acceleration technique.
Right.
Right. So if you're doing, the more sequences you're going to do, the more you want to lean toward the scan acceleration techniques.
And you say it's like tailored to the pathology of the patient, but also I imagine dosages as well, because I know we mentioned that before. You and I were talking on the phone. You were talking about hemangiomas, and so are these also considerations that you consult a radiologist for?
Oh, yeah, absolutely. Because you've got, in fact, it's interesting. There's a paper that just came out. It's been in a lot of the news sites. Talks about using half dose of GAD on patients who have a meningioma, and I'm thinking, seriously? I mean, we've known that for years anyway. Just, I guess not everybody knows it. But, because I remember one time, the patient was a follow-up meningioma. I was injecting with whatever agent, and I probably got about a quarter of it in, and the vein blew. It was hand injecting.
Right.
And the vein blew, so I just stopped, and radiologist said, "Oh, go ahead and scan it, see what you get." Of course, it, lit up like a Christmas
Yeah,
tree.
you
I
don't
mean,
even
it's,
know, yeah.
it's no problem, and we were talking about it. I remember talking about it with Don Mills, radiologist, and he said, "Well, it's extra axial. It doesn't have a blood-brain barrier, so it's, it enhances right away." So yeah, you've got, depending on what you're doing, internal auditory canals. You can do a lot of that without contrast, because using these balanced gradient echoes, you can see the 7th and 8th nerve really well. You don't have to have contrast, but even if you did, acoustic neuroma is kind of akin to that. It's a extraaxial lesion, and they light up with very minimal amount of gadolinium. So yeah, it can easily be tailored below standard dose.
for the purpose of resolution, do you also consider, like, say you work at a facility that has a 1.5 and a 3T, which would you prefer to use? Or is that whichever
Body
one's
part.
available?
Well, yes, it can be, but it's also, are they coming down from the floor? Are they on a vent? Are they on, bubble pap? So, what equipment's going in with them? What equipment's needed? What's available? As you said, is it, a body? Is it a cardiac MRI? Obviously, you're not going to do that on 3T. Is it neuro? So I think that's the same with any adult imaging, right?
Yeah.
You play it out and see, all the pieces that fit.
It's a technical, but it really shouldn't have anything to do from a standpoint of like SAR.
Right.
Because,
Right.
2 watts per kilogram on a 3T is 2 watts per kilogram on a 1.5.
Right.
System warns you. Yeah.
It just
Right.
gets there quicker. It's just, I don't see that it's that big of a deal. I go back to what Nancy said. I think it really just kind of depends on what you're doing and what capabilities you have on the particular.
Because immediately what comes to mind is where we work is we recently got a 7T and the bore is smaller.
Mm-hmm.
The head coils, they're smaller, and it's just screaming for a baby to be put in there.
Well, see, but 7T, the FDA guidelines, first level operating mode, normal operating mode.
Right.
7T is actually first level control mode. And if the, let's see, what is it? So 4 months of age or less, 8 Tesla's exposure. But because it's first level control mode, probably wouldn't put a kid in a 7T.
I know that I've seen a lot of new technology come out with these neonatal units. And I know sometimes they aren't even 1.5 or 3T. They're even, less.
Well, the
usually
one that's made by Aspect is the big box thing you slide the baby in is a 1 Tesla magnet. And I actually did some work for that company back when they had a wrist scanner, and they just took that technology and moved it on into this neonatal thing. So it's a proprietary design. So I'm not really, they'll tell you what it is, but they create a box out of these neodymium, however, I've never known how to pronounce that. But these neodymium plates, it's one of the most common metals for making magnets, like in microphones and stuff like that. You know that, huh? Okay. So anyway, so what it does, you take this metal and expose it to a high electric field, and it becomes magnetized.
Right.
So they have this proprietary design where they make this little box that's literally no bigger than that. And it's 1 Tesla.
Right.
Okay, it's a 1 Tesla permanent magnet, only because it's closer together, right?
Right.
So so they're that's at 1 Tesla. I know the portable units that are out there. At least one's been out there for a while. Others are in the works. They're much lower field, and
Hyperfine comes to mind, right? I think it's
I mean, it actually with their artificial intelligence recon, it's not so bad.
Right.
Really, is kind of impressive, quite honestly.
Right.
But for the larger head and stuff like that, I think eventually what I'll bet you see is some of these vendors develop pediatric specific coils, because in that 0.64 millitesla magnet, the coil is the transmit and receive head coil. So you can make a smaller transmit and receive head coil, and that wouldn't surprise me to be a development down the road from them.
Is that a hint?
No, I'm just saying that wouldn't surprise me. It seems logical to me.
So it sounds like, just based on your recommendation, if you're going to be scanning a pediatric patient, the smaller, you're going to want to lean towards a flex coil.
Oh, absolutely. I mean, if I could do that or whatever. One of the things, let me say this before something else came to mind about that, differences. And we'll talk about some safety stuff. But one of the things that came to mind that I really want to caution people against doing, so Nancy will see if you agree with me or not.
Oh, okay. It's tense.
We'll see. If you've got a transmit and receive knee coil, some of those just scream for putting a baby in it, right? Especially neonate, very small. Yeah. The problem with that is the software in the magnet, for SAR estimations and stuff assumes you're putting a knee in there.
Right.
And software estimate on a knee is vastly more liberal than software estimation on a neonate. And so strongly
That's clever
recommend
what
you
you
do
did
not
there.
strongly recommend you don't do that.
Right.
For sure.
That's
Oh no, I'm right up there with you. I mean, we have the head coil, right? We have smaller size head coils,
Right.
and yeah, they fit in quite snugly.
I've always been interested because I've, like Robert, have never scanned pediatrics really. Maybe a little bit when I was very new my first year doing MR, but it was always under sedation. But I remember like keeping the room temperature was a kind of a big deal too, right? Like how is that managed?
Well, this is one of the challenges. One of the challenges is that anesthesiologists, and then I'll tell you this safety incident, the anesthesiologists in surgery are concerned about the baby losing temperature, right? Because it's cold in there.
Always cold, yeah.
So they wrap them up. They pay a lot of attention to that for loss of temperature. And when you put them in a magnet, you're actually going to increase body temperature.
Yes.
Okay,
Right.
so you want to be careful about how you, for example, let's talk immobilization. That's kind of a good time to bring that up.
There you go.
You have a lot of these devices now where you put them in them and you kind of pump them up with air and you wrap them
So
up.
that's what we would use, a papoose, we called it.
Yeah,
Swaddle.
but
Yeah.
the problem is
And they work really well.
well. It holds them still, but the baby can't cool.
Yeah.
Yeah,
You can't dissipate the heat.
they're sweating when they come out. Oh,
Are these
poor
single
thing.
shots giving off a lot of SAR?
Well, the highest, yeah, because SAR is proportional to the square root of the flip angle, and so you've got a 90 followed by a buttload of 180s. So yeah, they're pretty high SAR. But then again, if you do a lot of them, like I said, the kid just can't cool.
Right.
And so I'm very leery of these plastic things. It's the reason I don't like the disposable shorts and clothing for dressing patients, because you can't sweat in those. I mean, they don't breathe, and it's not comfortable.
Right.
And so I'd be very cautious of that. The story that always goes along with this cautionary tale to people is there was a academic pediatric facility, a young child with a known brain lesions brought down for an MRI, and the anesthesiologist insists on wrapping the baby in a space blanket. It's what you use in surgery. Space blanket's got a metallic backing on it and should not have been used in MRI. MRI technologists have to maintain control of that environment and have to be cognizant, aware, and control what goes into the environment, and especially what touches a patient.
yes.
And anyway, so bottom line was when they got the kid back up to the expensive care unit, he had like a little burn, a lesion. It had a lesion. It was a funky looking lesion. They circled it. 5 days later, it was a full thickness burn, and they had to excise it because they couldn't close it.
Right.
And so it went to the FDA's attention and everything. There was some obviously lawyers involved and stuff, but you've got to control what goes in. I'm not worried about a kid getting cold in MRI.
Right.
I don't like wrapping adult patients in blankets.
Right.
So
because
what's
they
your
can't cool.
solution then? Like, what would you?
Well, let's
Yeah.
talk about how you immobilize
Yeah.
them.
So the swaddle, right? So a feed and swaddle, you swaddle them in a basic receiving blanket.
Which is a position they prefer to be in anyways, right?
Most of them.
Well, me included. It's kind of like, I've noticed the older I
Get
get.
over here, you.
Well, no, I've noticed the older I get, it's
All
like
hugs.
I have to stay home at night. I have to go to bed early. Basically the things that were my punishment when I'm young are now my lifestyle
Yeah.
when I'm old.
I like that. I like that, Bill. That's a good analogy. But so with the swaddling, the question is always, who does it? How, is it the nurse who's done it a bunch? Is it the technologist who feels the most comfortable? We have parents who feel more comfortable because that's how, they put their child to sleep. They have come in with their own swaddle with, Velcro and zippers, and we have to explain, nope, those can't go in. We'll do it the old-fashioned way, and it works, and we know. One of the difficulties that comes from it is that if the patient, they wish to monitor the patient, right? And so you've put them inside the swaddle, and then they unswaddle them, and they start, putting on the devices. So it's putting on the device, having the wire come out, and then doing the swaddle and things like that. And the same thing goes with the patient armband that identifies them. You need to take that off before you swaddle them, because the technologist should, and I'm not saying they're wrong, they need to do the timeout to make sure that they're scanning the right patient. Right. They need to unswaddle them, and you've done away with all the good things. So taking that armband, taping it on the outside of the swaddle so that the technologist, radiographer,
smart idea,
can identify them. Right. And so it's just those little things. But again, if you're doing it every day, it just becomes second nature. But when you don't, and you have one patient come down a month and they're a pediatric, then you go, well, dang, that didn't work.
I got him to sleep.
Yeah,
okay, take it off. We got to hook him up to EKG.
And there's a whole bunch of prep that can go into that. The things that aren't considered are babies have a routine. Bill has a routine, I've heard. Yeah. So you can't necessarily schedule the MRI when that child is going down for their nap anyway. It's ideal. I mean, if you can work it out, bravo. But explaining to the family that if your child eats every 3 hours, we want them to eat right before that MRI. So you need to withhold their feed. They're going to be angry. They're going to be cranky. But I promise you, a 4-month-old is not going to recall back when they're 7 and go, you didn't feed me on time on that day, February 12th or something. So
that's just so they're less fussy during the exam, right?
Whoa, so they're hungry, they're cranky, so that when we feed them, we swaddle them, they're ready to, they're like, okay, now I want to go to sleep. We also advise parents to bring someone with them, someone who's there beside the child in the car seat, keeping them entertained, keeping them awake. Because again, we want them sleeping for the scan. We want them awake on their way in and cranky.
They arrive hangry.
Hangry. Yeah, that would be a whole commercial we could do. So we can't give them things like we used to. Bill and I were talking in the late '80s. We used to give chlorohydrate to every child. That was the scariest thing.
And that stuff is like, you give it to them and then you wind up with a drunk 5-year-old.
Yeah.
And there's nothing worse than a drunk 5-year-old. Okay.
No.
Oh, Reggie. Okay. Well, whatever. But then the other thing about it is it has chlorohydrate has very significant respiratory suppression things. So you really got to kind of watch that. And then the other part about it was you give them enough and you finally get them down there sort of halfway cooperative. And then they take them and put them in the car and we did
go
to sleep, and even to a point where you got to watch their airway. So chlorohydrate was nasty. It was
nasty stuff. We don't use that anymore. But so yes, so there's a whole setup right before the child comes in that the parent needs to be aware of, family, and what's going to happen, when do they arrive, and then talking to the family and say how long does it take for your child to feed before they kind of fall asleep. So knowing all those, and the technologist then yelling out and saying, we've got 20 minutes, start feeding, and then, you do the swaddling and things of that sort.
So the stars have to kind of align, it sounds
They have to align. And I think, doing this, and, I keep saying I'm blessed to be in a pediatric imaging place. We do this enough. And so we also know that we talk to the parents, the family beforehand, and, how does your child go to sleep when they go for a nap? Do you have a family of 6 kids where it's noisy and there's chaos and you're vacuuming because you need to get things done? That kid is used to noise. But if this is a firstborn and, we're all a little bit nervous about our firstborn child and they're brilliant, and so we keep everything quiet, putting them in the MR is going to be a real shock to them. So there's been a lot of discussions, and I've tried it. Again, I'm in research, so I get to talk to the families, and that's not always the case when you're doing clinical imaging, but discussing with them playing noise prior, right? So the week before, played at a volume of 2, and then each time kind of cranking it up. When we used to burn CDs, we could make I know, so Reggie laughs. We would send them a CD of MRI noises. Now we can just say, hey, go online. It's on YouTube. You guys could play it. And they would play these CDs for the child the week before their MRI. And so it's a whole long process if you want it to work the first time. And I understand people don't have that luxury. And and your eyes got big on. Yeah.
Well, it's kudos to you for even considering that. Something I've never even thought about.
Yeah.
To actually prepare them for the exam itself,
Well,
because
see,
it could be a
that's it.
traumatizing experience.
Because you just
Sure.
expect them to behave like an adult, and
Yeah.
like they do it, and they don't. So and that's the feed and bundle thing. When you consider other types of either deep sedation or general anesthesia, then you've got other people in there that you've got to worry about.
Right.
The anesthesia crews and stuff like that. And it's always good to have a set team of people so that people are used to doing it. They're used to the environment, that sort of thing. Where I worked, the rule of thumb was above a certain age, I forget what it was, I'm going to say 10, 11, something like that. They had to try it cold turkey. If they couldn't do it cold turkey, then they'd go general anesthesia. The group I worked with, they preferred, because I asked them this one time. I said, instead of just sedating the kid, why general anesthesia? And his response was, we have them under control. We've got control.
You got an airway.
Got an airway. We have control of them. And they were really good about asking us up front, how long is it going to be? And so they would bring the child to a level that would last that long. So when we got through, it didn't take them long to wake up. They really timed it out well. I mean, they took pride in that.
Right.
So it helps to have that kind of team, because there's nothing worse from a safety standpoint is having all these people you got to be watching while you're trying to focus on the scan itself. So again, it helps to have a team. And again, from a safety standpoint, it's really critical that you pay attention to all the leads and the wires and the stuff when you've got an anesthesia case. If they're swaddled, you get that on first. Make sure you don't have any loops, nothing's touching the baby.
Mm-hmm.
And then even on older kids that are under either heavy sedation or general anesthesia, it's the table coming in and out, stuff shifts, stuff moves. And you want to just always make sure that checking front at both ends of the magnet, that you don't have any, leads or wires or stuff, happening like that. And,
For sure.
and the other thing we were talking about kind of along that same line, depending on how you're doing this, is immobilization.
Oh, yeah.
Right.
Yeah, there's,
Duct tape, right?
Well, hey.
Oh, that was going to be my line. What is tape is, in the answer to the question, best.
God's gift to MRI tech, 2-inch tape.
Right.
I mean, when our scans were 20 minutes, everybody had a piece of 2-inch tape across their forehead. There's nothing wrong with putting 2-inch tape across them.
Is that why everyone's claustrophobic these days?
Yeah. Well, a lot of I've had techs push back on that, and they'll say, "Well, that's restraint." No, it's not. It's immobilization. Immobilization. I mean, it really is. There's a definition between between immobilization and restraints. Immobilization is a temporary method to limit motion for performing a procedure.
Oh.
Nice definition.
Okay.
Yeah.
Wow.
Right.
You looked it up.
Yeah.
I think, and we're leaning kind of towards baby heavy with this whole pediatric imaging, but it's more encompassing. So there are kids up, and like for the older kids, like, is that something you would be more willing to let a parent in the room for, or is it just kind of...
This is a mixed bag.
Is it
in my opinion.
counterproductive? Is it...
Depends on the parent.
There you go. Read the room, right? So if you have a parent who isn't chaotic, Bill acted out. Okay, act out chaotic. But if they're pretty chill, it's like their third, fourth kid. They know, the ropes. They're like,
Right.
I personally dissuade them. I say, I will be in there. I will be in the room. We will have someone. We will be watching. And it's not because I don't trust them. Here's what I do see more of is the baby will jump when the scan starts, and it's a startle response. It's expected. We know that's going to happen. We're going to throw away the first couple bleeps. But they go back to sleep. But they're now banging at the window or saying, take them out, take them out. And if the parent does go in the room, obviously we have to get them completely gowned and take everything off. And so that does help dissuade them from going in the room. But we do say, listen, they are going to startle. They are going to jump. Don't panic. Right. We've done this before. We're
Even
watching.
Under sedation?
Oh, I'm
Or
talking
no,
about, yeah,
we're talking
feed and bundle.
bundle.
Oh, for sedation, I don't think I've ever thought of a
No.
parent going in during
No,
sedation.
they're typically not. They're there when
Yeah.
they're when they go to
IV or
sleep,
something.
but
and then wave
they
goodbye at the
go.
door.
Yeah.
Oh, I'm sorry.
Yeah.
No. Yeah, because there's different
Either
scenarios.
no sedation, or some kids would do a lot better if the parent wasn't in there.
I agree. I've
Especially
seen that.
as you get older. And to Nancy's point, yeah, you dress everybody. You do this anyway. You dress everybody Pharos free to go into that room,
Right.
which includes the parent. You know, you
100%.
got to screen them just as equally as you screen a patient, and that does dissuade them in
Because
cases.
Obviously, I'm an MRI tech, but I'm also a parent. As an MRI tech, I don't want the parent in the room. As a parent, I want to be in the room.
Right.
So
Yeah.
But so you're the one reading the room. You come in. I know you're chill. I know you know what you're doing.
Yeah.
So that you're not going to react. So it's just having that conversation with the parent prior to going in.
yeah. So
And you
it's-
get that feel.
I mean, my granddaughter's 12 now, but the last couple of years she's had a couple of MRIs, and she always wants me to go in the room with her. So I just go in the room and just
Right.
sit there and keep my hand on her leg or something like that.
Do you sign autographs while you're there?
I usually just, it depends on where we go. So there's a lot of newer
You
techs
wear a
in
mask.
town. Maybe somebody doesn't
know.
So, and I just,
You're humble.
Yeah.
I just keep
It's
quiet.
it's when I hear someone say, "Oh, I went to Mr. William Faulkner's lecture." I'm like,
If only you knew.
So you need to come out with a shoe, and that way you just live on forever, man. Like Jordan.
Shoe.
Yeah, an MRI shoe. Just gotta have no metal, I guess.
My luck,
Like
if I
a
get anything
version of
named,
the Crocs
if I
or
get
something.
anything named after me, it'll be a rectal disorder.
Okay, we're gonna cut that one. Reggie's- okay, wait. We're digressing here. Where were we?
Well, okay. One of the other things from a safety standpoint you were talking about with the parent in there and addressing the parent and stuff like that, that you really have to take consideration of is hearing protection. Because the kids, once a kid gets, I mean, I don't know, I'm certainly no expert on this, but I just know, I always remember, once a child gets above 5 years of age or gets up there like that, they got about a human-sized head.
Yes.
But the head above a certain age, it
Right.
doesn't change.
Right.
Okay.
Right.
But very young kids, this is very problematic because the materials, the stuff we're using was designed for an adult. I mean, that's always been a problem in MRI in general.
Right.
So what's the first step? I mean, with my experience, you just cut an earplug in half, right?
Sounds
In-
good. Okay,
theory.
can we go back a step?
Yeah.
We have to acknowledge that no hearing protection that we use currently in an MRI was ever designed for an MRI, right? We're just really
That's true, yeah.
innovative
Right.
technologists. We find what we can and we use it, and we've adapted these
I mean,
things.
I've had so many patients go, I know how to put these in. I shoot guns.
Well, that's
That's a question.
good, because if they do, then yes, they probably do know how to put
Right.
it in.
But a
right?
2-month-old hopefully is not shooting a gun.
No.
Hunting, but not shooting a gun. Using bow and arrow. It's much safer.
Yeah.
So no hearing protection is for an MRI.
It's
We've
almost what, industrial?
Oh, yeah. Okay. Can I pull
Oh,
things?
yes.
You have
Love
visual
that.
aids?
Okay. Oh, come on. Some fell through here. So there's different varieties of hearing protection, right? In an MRI. And I didn't bring one variety. So, all right, let's just keep going. So there is earplugs. Right? Everybody knows earplugs. There's strong ones, there's soft ones. Adults like the soft one because they don't itch as much.
Is this considered the hardest part of scanning neonate or?
So that's a
Not
really
image
good.
acquisition.
Well, it's basically the part of scanning where you actually don't know what you're doing.
Right. It seems like
Yes.
I don't
Yeah.
even know where to start.
Or you just crossing your fingers and hopes it works. But yeah, okay, so
Okay, but no.
Right.
Let's go on to that.
Exactly.
How do you know? You
Right.
can ask an adult.
yeah.
Right.
Yeah.
You can't ask a 2-month-old,
Right,
right?
right.
You just have to.
Adults, and this, let's say this for people listening, if you got an adult, you look at them straight on. If they're sticking out like Shrek, they're not
Right.
in right. So
Right.
they really should be up close to the ear. The other thing you can do is you can have them, or you can do it to them, put their hands on and off their ears like this. Because if you do this now while you're listening to something, you can hear a difference between on and off your ear.
Right.
But if you've got hearing protection incorrectly, you can't hear much of a difference.
Oh, nice. Okay.
Right.
So that you can do. But
So there's earplugs. They go into the canal, as Bill just perfectly explained, and the purpose is to then expand and take up the entire canal, right?
Right.
You don't want any airflow, even paper thin, going past that, because then they're pointless. You didn't
Right.
put them in. So
and that's the thing, though. Let me point out, for hearing protection to work, it's got to go, for a plug type thing, it's got to go in the canal.
Right.
So
In
it's
the
got
canal.
a high margin of error, it sounds like.
Well, okay, so if you ever had, because I'll put a little strap around it, but I wear my AirPods
Oh, yeah.
when I'm like riding my bike or something like that. And so, especially riding a bike, but you can hear the wind around them. You ever done that? You know, had the AirPods in, you
Oh,
can
yeah.
hear the wind. Well,
Yeah.
they're not sealing the canal.
Right.
Yeah.
Right.
Good point.
So now we have to adapt an adult earplug to a child. So like you said, we cut them. I have actually seen people cut them horizontally. So they make a circle, right? And then they
Right.
take this and they take tape and they put it right here at the tragus, right? And but no.
They're
And here,
like,
well, but no, they
No,
they
it's
sh-
not in the canal.
it's not in the canal.
Right.
So you've just wasted, your
Ah.
scissoring technique. So then there's cutting it lengthwise. But if you cut it lengthwise, as you know, now it's a half moon. It's not round. So even if you squeeze this, you put it down in the canal and it expands, it's still a half moon. Right? So I think what a lot of people have gone to when using earplugs is to cut it on the diagonal. So you get two, and the end will kind of look circular. I did this with a pocket knife, so it's not a really
Hey,
good.
it looks like you nailed it to me.
Woof. So at least the top, right? But now we've got a problem. So we do this, we squeeze it, we push it in, is they're longer. So then you have to actually clip the end point so it's not pointy and you're not jamming this in a child's ear. Because again, going back to the pug, and no offense to anybody, their ear canal is different. It's smaller, it's shorter, and things like that. So
Right.
these are the things that go into the ear. They have to go in. They have to be flush with the tragus. And if they're popping out, as soon as you put padding in, you're going to knock them out. How many times do you do that with an adult anyway? And they go, you knocked my
Let
hearing.
me tell you the funny story.
Oh,
when I was
Bill has a
scanning-
funny story.
Yeah,
Oh, do you
go
need some
figure.
props?
No.
Okay.
When one particular anesthesiologist who always came down there, they just put the kid to sleep, got him sleep ready, put on the table or getting the magnet. And so I got the earplugs and tried as best I could to
Right.
get them in the kid's ear. And the anesthesiologist said to me, "Why are you putting earplugs in? He's asleep. He can't hear anything."
I've gotten that before,
I've been a
too.
part of that,
Well,
yeah.
Nailed it.
but now, see, the problem with that
I'm like,
is
that doesn't-
it's not volume; it's air pressure changes, right? It's pressure changes that's going
Right.
to impact the ear. So it's like if a tree falls in the forest, nobody
Right.
hear it. So it's not that they're asleep and not hearing. The other thing that's interesting, and this is actually in the IEC manual, when a child is under anesthesia, okay, not just feed
All right.
and bundle, but when
I'm
under
listening.
anesthesia,
Under anesthesia.
the muscles relax in and around the stapes in the inner ear, and they're actually more sensitive to it
Oh,
because that's what it says. The IEC says
right.
smarter people than I, but it does put them at a little more risk. This is for the sedated or general anesthesia, so it becomes more important. But the guy was thinking, they can't hear, but they're still getting the
Right.
air pressure changes,
Right.
So have you found a good solution to this?
Well, but we have more props.
Oh.
But
Okay.
wait,
But
you've
wait,
heard it
there's
yet.
more.
More out there.
So a lot of people go with mini muffs, right? And so these again were not designed for MRI. They were just on the shelf at the hospital. They have a NRR that's noted, and we see NRR, noise read. Oh, we can use them in an MRI, and you can. These were for a NICU. And so they are intended, and you can see that, there's a hole there. So it's supposed to be that the entire ear, the auricle, all the fleshy part, has to be inside this. These were made for kids in the NICU, in an incubator, and preterm. No one reads that on the packaging. So I've seen people slap this on a 4 or 5 month old, and it's not going to work. And
I have.
yeah. So, and do you know there's a right and a left, even though it's not marked? There's a right and a left. And a lot of people use this little pull tab. They think that's for like putting it here at the top of the head so it doesn't stick to the skin. Well, then you've just defeated the purpose. So you can pull it off like a lid of yogurt. This is actually, it's kind of smart. This is along the jawline, because when you have a baby in there, you usually have a pacifier. They're suckling.
Right.
This is actually to go around the chin so that there can be suckling.
Oh, I still have
But if you don't have this gooey, sealy thing perfectly attached to the head and the ear, the auricle of the ear, and there's a front and a back, fits inside, you've done nothing, right?
Even if it fits, okay.
You can't commit?
The pack, you can't commit because you can't get.
Sorry,
Must have
I know.
But even if they do fit, if you look at the packaging label says 7 dB.
Yeah, and so I was wondering about that. As far as like FDA, do they have, or does ACR?
It probably doesn't mark.
But
They don't
the
market it
ACR
for MRI, probably.
The ACR, bless their hearts. You know, the ACR, even in their most recent manual,
Yeah.
they still say recommended. Hearing protection is recommended. In any facility I would manage, hearing protection is not recommended. Hearing protection is required. Speaking of the gun range, go to the gun range, you don't wear hearing protection, they won't let you shoot.
Yeah.
Right? And so this is,
Yeah.
you work on a construction site, you got to wear steel-toed boots. You've got to wear hearing protection. I mean, it's required.
Right.
It's required. Right. Even if the patient were hard of hearing or even deaf,
Right.
you should use it because you don't know if you'll cause further damage to the ear. So again, to Nancy's point, these were designed for the NICU. So in an incubator, which doesn't have any sound levels anywhere near close to MRI, so whatever sound reduction they get in a NICU is irrelevant for MRI because we're at a much higher level.
Right.
It's different frequencies. It's different.
Right.
I mean, I've seen some test data that shows in an MRI, those mini muffs barely do 2 dB.
Right.
Oh.
Well, and I think, Bill, there's the false understanding that when you add these on top of each other, you get a cumulative.
I was wondering that too. Yeah.
Not really. Not really. You know, there's an equation, right? It's a square. We're not. I was told there'd be no math.
Yeah.
So yeah. So you don't add them together. And then you're assuming you put them on properly, and you're getting all of the effects that you hoped. And usually, when you're adding more, you're making yourself feel better as a technologist.
Right.
You're not.
You're actually not doing anything.
Yeah,
Again,
yeah.
As long as if you're putting stuff on here, but you're still not going down the canal,
Right.
then
Right.
you're really
Right.
not getting any
The same
significant
problem.
hearing protection, and they can't tell you. Adults can tell you.
Yeah.
They can't tell you.
Yeah. And then there's the waxy putty stuff. It's dental putty,
Oh.
swimming putty.
Can I feel that?
Like
Yeah, because it's creeping me out. Thank you.
And
So
swimmers and-
yeah.
Well,
So
swimmers, that's what it's designed for.
that's what it's designed for, right?
Right,
But
right.
when you jump in the pool, you know if the water gets in, you know if you need to take them off.
Right.
So the deal with that is it says on the labeling, do not put down into the ear canal. So now you're just
Oh.
oh, the
And
light
a
went
lot
on,
of
Reg.
people-
The light went
a
on,
lot
Reg.
of people use this again simply because the school of thought is if I cover
Yeah.
the whole
I can just-
cover that, then sound's not going to get in, and that's not actually true.
Right.
I have a friend of mine who plays music. I play music too, but anyway, he plays saxophone, and he's very, very good. And he's oftentimes hired when acts come into town to play baritone sax, and he plays with the symphony when they do the jazz band stuff. Anyway, so he plays a lot, and he bought custom fitted ear, not in-ear monitors, but custom fitted plugs that
Right.
cover the ear.
With the latex.
But it comes in, they come in 3 different attenuations. So it depends on where he's standing on stage as to how much attenuation he'll use. Bottom line is it doesn't go down the canal. Sound still gets through.
Right.
What do you play?
Play guitar and banjo.
5-string
banjo
Yeah.
and guitar.
Yeah.
I played,
Tennessee, of course.
I
he
played
plays
since played since I was.
So is that
junior high school.
moonshine in your glass right there?
No, if it was moonshine in this glass, I'd be sleeping.
And so there's two more varieties of passive, right? We're not talking active noise cancellation, which is a whole different level. Passive. Right. So these are all passive. There's also the head muffs, and you see those a lot on kids whose, father is playing in the NFL and they're in the Super Bowl.
Something the other night, one of the ball games or
something.
Yeah.
And they're brilliant, right? Because they're a hard shell. They fit over the entire ear. Right. They're compressed against the head. Perfect. But getting that jammed then into a coil, and the purpose of coils is to use the smallest coil you can possibly use. Now you've got this. So now you've got these muffs that work, saying that, but if they're not protected against the side of the coil's going bang, 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 bang. It's vibrating. That vibration then is causing external vibration on that. So, again, it goes to the sound pressure waves. And
the other thing that reminds me, and then not to pick on Siemens or whatever, but they're one of the vendors that I can think of. In fact, maybe some of the others do, but I know GE doesn't necessarily provide it. I don't know if Philips provides one or not.
I don't know what you're talking about yet.
Headphones.
Oh, okay.
The headphones. Okay, the headphones are designed for communication.
Yeah.
And in fact, if you read the user manual, which you hopefully
we all do. Yeah, we all do.
I read that. I tell you, it's interesting though. I've seen texts or read texts and depositions before because they always get named. It's like, so tell me, have you read your user manual? And a good attorney will never ask a question to which they don't already know the answer.
Right.
But anyway, the point is, in the user manual, it says these are for communication only, and that you are to use hearing protection along with the headphones. So basically, you have to use minimum earplugs and the headphones. You can use earplugs only, but you can't use headphones only because they're only rated, I think, I have a picture of one. I want to say it's like 14, 15 decibels. I mean, that's what the rating says across the top of it. Right. So it's not adequate. But there are people that'll say, well, we use those headphones. We give the patient the option to use earplugs or not. No.
Yeah.
Shouldn't do that.
Also, with inadequate hearing protection, what I see a lot with techs is that they just use padding.
Yeah, and it's not in the canal.
Yeah.
See, that's the big thing. It's not in the canal.
Yeah.
Right.
If you're going to use padding,
it's more of support to keep, things in place and whatnot. But this does not have any value of NRR. It's not. Yeah. So, the last, I guess, passive hearing protection that we found is this device. It's called the DREAMIES. And again, it wasn't initially designed for the MRI. So they were using this in the NICU, and then it became a question. These babies are coming in on transport, on a helicopter, and that's just as dang loud as an MRI. Right. So how can you then take a device like this and I don't know, it's a clear device so you can see it, and it goes around the ear, right? Got pictures.
It also has compression, it looks like, with the strap.
Right. So, and you can turn this. So, not
cool.
every ear is the same. So I can angle it so it fits perfectly. It has a head restraint. It does have some soft gel on the back because, like I was saying, knock that. When it's made for the NICU, when you're looking at kids, their skin is more fragile.
And that material breathes as well.
Yeah, and it's soft, and it doesn't pull the skin away and things of that sort.
Especially, I just learned that the other day, like the neonates, like their skin is like barely a couple of layers. It's really
right.
Yeah, you certainly don't want to be putting tape across the.
No. So then the idea was transport, and when you look at the frequencies in a helicopter, they're very similar to an MRI. So that's how this became then. Let's test this in the MR and see what it does. And, it's small. It's a low profile. It does checks off all of the things that you want. And, and then,
the other thing that's important about hearing protection, Nancy mentioned it, is not all hearing protection provides the same attenuation over the same frequencies.
Right.
Okay.
Right.
And so the frequencies in the NICU are different frequencies than what you would have in an MRI. So the attenuation, the noise reduction rating is only one component of it. It's
So when you see an
frequency
advertised NRR, that's based off its like most favorable
Well, no, it's a
frequency?
global.
It's global. It's,
Okay.
usually it's A weighted.
Yeah.
Usually it's A weighted. A weighted is there's different. There's I don't know what D weighted. Somebody's all different letter weighted, but it's weighted for human hearing frequency response. But it is global. It's just across the board.
Right.
Not really frequency specific.
Right.
So when you and again none of these up until now none of these were designed for MRI.
Right.
Right. So the frequency.
Right.
Nice.
And so the lower frequencies voice, they want that to come through in a NICU, right? So they hear the mom talking and things. So the ones that are designed for the NICU, they don't suppress voice.
Or
This
attenuate,
does it.
yeah.
Attenuate. Thank
Yeah,
you.
right.
I knew he'd correct me at some point in the conversation.
Get it right.
Right. So human. So that's why this for NICU is okay, not for MR. Then there's the one that's for transport and MR. That's good for MR, but not good for the NICU and vice versa. So,
Does this come in like different sizes?
oh, look.
I got some big ears, even as a
I
kid.
know, right?
I'm telling you, my husband snores. Sorry, honey. I want an adult one of these. So yes, I'm still talking to them about that. Yeah. So everybody has the handy dandy tape, measuring tape that's paper, and so you do a typical OFC. Occipital frontal circumference, and then yes, they each have a range, and you can see that it. Of course, I told you I'm going to do it on screen. It's going to so it stretches, and so it adapts to different head sizes. So there's a small, medium, large, extra large, things like that. So
you could use it on like a 7-year-old that's under anesthesia.
I bet there's not one yet for that size. I bet I can get up to a 1 or 2. Their heads get big, pretty honking
By
big.
the time you, like I said, by the time you get around 5, 6 years old, I mean,
You're an adult head size.
Yeah.
Yeah.
Nice.
Yeah.
So,
And then you can get a earplug down in a canal, right?
Oh,
So
right.
the other thing is
Okay.
with,
Right.
with the small kids, not only is it canal small, but it takes these funny turns and stuff. So it's very difficult to get an earplug
Right.
well seated in a really small child. Again, they're not made for MR, and they're not made, and they're made for adults.
and I just want to say one more thing about passive hearing protection. There's a lot of question is, do you put it on before the child feeds? If you're doing a feed and bundle, do you put it on after? When is the? And I can't tell you I'm right. I can tell you what I've done.
You have a lot of experience.
Yeah, through experience.
Empirically determined.
Wow, you were just pulling them out, man.
You woke up knowing you're going to use that word at least once today.
I asked him to use that in the podcast today, empirically. So the baby's feeding, family's feeding the child, and, putting the earplugs in now or the restraints in now, they don't, it's like going up a mountain and you need to pop your ears. So they can't regulate the ear pressure they need. So I do not put hearing protection on prior to them feeding. Okay, I let them feed, and then when we're going to burp them, and please burp a child because you don't want the child to burp lying down flat in an MRI scanner. That gets
Any
ugly.
good burping techniques? Can you?
Oh, I will. Okay, but let me just say
Bill?
one more thing. So, yeah, Bill, I will hold you up, Bill, and I will show you.
Reverse Heimlich.
So putting these on after the child is eaten, they're still awake. We're still going to burp them, and then putting it on and then prior to going into the scanner. That's kind of
So
my
pre-burp, they go on pre-burp.
pre-burp it, but post-feed.
Post-feed,
Pre-burp. Okay,
pre-burp.
I'm good with that.
There's a window of opportunity.
Yeah. We've got some time. So this is something I learned from a nurse in the NICU. So I was doing the very nice, it's okay, honey, go to sleep nice and soft. And I'm like, what are you doing? I'm like, I'm just being calm. And they're like, okay, this child has been in the womb and heard the heartbeat of their mother. And, now you have this on and they're probably hearing, their blood flowing. And the nurse said, you want to do this, bump, 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 bump. I don't know if it's on their shoulder or on their back or on their bum. Some kids like their butt pet. But I do a more rhythmic and not soft. I mean, you want to go bing, 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 bing. And it does seem to then go with what we're trying to get them to do.
Yeah.
Yes.
Oh, interesting.
Yes. So the soft little touch.
Sounds like a lot of thought put into it. And it helps if you do this often and you don't work at see, like when I worked at the place I did 5 years ago that did pediatric imaging, it was every Tuesday. Tuesdays was ped sedation day.
Right.
Yeah. That's the way it was at Erlanger. It was Tuesday or Thursday or whatever, and we had two rooms. One was bigger, and that's the one they always did all of the anesthesia in. Let me say this before we get some more about this
baby
stuff.
Goes away.
For sure.
Yeah, but it's real important, like I said, that you safety standpoint that you have teams that do this a lot. But when you're talking about general anesthesia, which is why I think one room is a good idea, all this equipment stuff should stay in MRI and should be refreshed in MRI. You don't want it getting out, because if it gets out, you don't know what's coming back in with it.
Right.
Anything that's going to be used in there, MRI needs to provide.
And an example of that I've seen is a lot of times the nurses will come down and grab our MR pumps. Right.
Yeah.
And just because they want to program it, but
then
they attach things to it. Yeah.
Well, see, we had that happen at one site we were working with. They kept everything down in MRI, but one of those pumps with a non-ferrous pole got back up on the floor, and for some reason the nurse swapped the pump with a different pole. They didn't get caught until it brought into a magnet again and actually got slammed into a magnet. So you really want to keep control of this stuff.
Right.
Yeah.
But anyway, so I was going to ask you about, you ever do anything else with this? Because if you got to get them in the, get them in the coil, get them in the thing. So what about for like support and stuff? That's what that's for.
Yeah, as you noticed from GE, what,
So
1987?
that's a GE coil right there, or a pad, I should say, if I've ever seen one.
Right, because we know the green, the blue. So these fit very nicely alongside. And, the initial thought was more of preventing them from moving side to side, support.
Right.
But it also added support to the side, keeping this pressure against the ear. And there is a belief that this is actually then adding to the noise reduction rating. I mean, it's not going to take it away, right?
Right.
And as we were saying, you don't want an earplug or a muff or anything to move,
Right.
because that's only going to enhance it. So this, along with the muffs or the DREAMIES, then keeps it safe, secure, not moving, and then we're pretty much guaranteed that.
So working where you do with
Yes.
pediatrics, is many years that you've been doing this. This is what you highly favor.
This is what I highly do.
Right. Well,
Now, and I just want to say one thing, so someone in your audience doesn't complain or write in. I would not put them in an outfit. We just didn't want a naked baby here. But as you know, so when a child comes in, they have to be completely diaper, everything off, because you need to check for metal and everything like that. So they do not go in with this. Don't worry. This is just
you already
for
know the comments.
Yes, I know. Nancy, why did you show a child? Because
I just want to ask, all right, so everyone who is watching is interested in hey, man, we need something like this at our facility. Where can they go get more information about, this NEATCap right here that this baby has?
Yeah, the DREAMIES NEATCap. You can find it online. I'm sure we're going to put up a little thing on the bottom. But, and I've also, cheap plug, done a publication on this device because, again, it was just a passion I had. And I don't know if it's passion, it was annoyance that I couldn't find anything that I could go back, sit at the console, and be comfortable with what I had just done, right? There was nothing that said to me, okay, I feel good about what I did. So the anecdotal stories, things that you can't put in publications or posters. I actually had a child and put this on. They were still kind of awake, but I'm like, they're so chill. Let's just put them on the scanner. Let's put them in the coil. Let's start getting things set up. And so we were talking, and the eyes of the child, these are open too, it's weird, looked and just kind of gazed around with this bedazzled look of what the H-bells is going on here, because I can't hear you, although I see your lips moving. And so the person with me said, what are we doing? I'm like, let's go for it. They were awake, but it was just so quiet. Then we put them in, and it actually baffled me. I was honestly surprised.
Wow.
And I'm like, I put them on, right? So, yeah.
I think it's important that to point out when we're talking about this that one of the things that I've learned here recently was the fact that what we're doing again is made for adults and wasn't even made for MRI. So I think this is something we need. I think this is something people should look at, because in the adult population, based on a paper that was published several years ago by some folks at the FDA, where they looked at 10 years of patient injuries reporting to the MAUD database. Of those injuries, I think it was like 6% were hearing related. And most of these, if you go on the MAUD database and you look at them, most of them are patients who are reporting tinnitus or tinnitus or whatever you say it. You say
He's from
tomato, I
Tennessee,
say
don't
worry.
tomato,
Yeah.
you know. I don't know, but you know, they were reporting that. And in fact, I had a colleague friend in Chattanooga, managed a facility and MR background. And they noticed that when they put in a 3T, all of a sudden they were getting complaints from patients about hearing that came from the 3T. And I said to her, I said, well, are your techs giving the earplugs to the patient, go, here, put these in? So there's a large population, probably not going to know how to put them in. They just, you know, they don't get them in their canal. And, or are the techs putting them in, but they don't know how to put them in?
Do you have any tricks on for, like, say, for an adult? I know we're on pediatric imaging, but
well, okay, but you know,
I've heard pull the ear.
This is way, this is way you're supposed to put them in anyway. You're supposed to pull the ear back, and that kind of opens up the canal, and then you can get them down in there. And then once you get it down into the canal, hold it for about 20 seconds to let it expand.
That's what I do. And then what about like opening your mouth?
Yeah. Well, you know, like I said, I just, you know, typically will do that,
Yeah,
or you walk around behind the patient, and you just talk in a very low voice, and they don't hear you. You know,
right?
Because if you talk to them straight on, it's like, are those in correctly? They're going,
right.
What?
Right.
Okay, they were. Yeah, just, you know, just pulling back on the ear and then getting it down in there and then holding it and then seeing if it's flush as much as possible.
But also getting down low and looking at their ear canal, because everybody is just different. And see which
yeah.
direction.
Well, like I said, I actually have very small ear canals, so I have a very small range of ear pod, you know, little rubber tip sizes that'll fit in there. They just don't fit in my ear very well. That's why gun range, I don't use earplugs. I just use the over the ear stuff, because I just can't get earplugs in my ear well.
I think this has been a great episode. We haven't covered pediatric imaging, and so this is a great one to do. Circling back, though, because I think one thing we didn't really cover with the image acquisition thing was I just wanted to talk about specifics with the sequences. Like, we're talking about field of view, resolution, but we didn't really talk about, like, slice thickness. Like, do you want to do less averages or concats?
Well, okay, so if you've got artificial intelligence reconstruction. Okay, let's just start with the Bing Bang Daddy right now. If that's if you've got it, okay, then what I want to do is I want to jack the receiver bandwidth up as much as I can. Mm-hmm. I don't care if it's going to get, you know, lose SNR, but what that's going to do is that's going to compact my echo spacing. It's going to make stuff less blurry, gives me a chance to use a longer echo train length, turbo factor, whatever, and then drop the number of averages down to 1, so I can just get it as fast as I can and let the AI recon do its magic. Okay. Right. Now, some AI recons will also do edge sharpening, some won't. Right. So you have to know you got to know your particular brand of AI that you're using, and because if it does help with the sharpening, then you can drop back the matrix a little bit. You know, and that sort of thing. So assuming that, because that takes all the rules of thumb that we used to have to worry about, takes that out of the way. The thing that I think is important to look at, so let's say brain imaging in particular, is looking at the age, like we've talked about, looking at the age of the child. Spin echo, for example, for T1 weighting, of course, what everybody's done since day one, right? Mm-hmm. It was interesting, though, in 1985 on the GE15 that we actually had 2 pulse sequences. We had a spin echo pulse sequence, and then we had this thing called inversion recovery. And if you looked in the classic textbooks, Brill Bradley and classic textbooks,
Blue Book,
IR, inversion recovery, was the gold standard for doing T1 weighted imaging, because with the inversion pulse, you stretch out the recovery curves and you get beautiful T1 weighted imaging with it. But it was a single slice technique. You only do one slice at a time. So in other words, if it took you 5 minutes to do one slice, it'd take you 10 minutes to do 2, 15 minutes to do 3.
Oh, you better
So
nail
basically,
that
we didn't use it. Actually, I did it once with a midline slice right down the head to see what it looked like.
Right.
It dropped dead gorgeous. Okay.
Right.
So then everybody was using spin echo. Well, spin echo sucks, quite honestly, for T1 weighting. It's not optimal, particularly in the brain. And in the early days, your TE, you couldn't get a TE lower than 20, 25 milliseconds, which really didn't help your contrast any.
Right.
So I think today, for T1 weighted brain imaging, particularly for young kids, I think a 3D that takes care of your slice thickness issue.
Nice.
Okay. I think a 3D of some inversion prepared type sequence, MP Rage, G's got Bravo. I think Philips calls it a turbo field echo. Vendors have different names for it, but it's essentially it's got a 180 in front of it, and that really helps with the gray-white differentiation, and especially if you're on a 3T. Okay, I mean, spin echo sucks worse on a 3T. So gradient echo is a much better technique. Because short TEs, you got no flow artifacts, you got very thin slices, real good gray-white differentiation. Plus, you can reformat into multiple planes, and I think that would be the sequence of choice for T1 weighted imaging, because I only need one 3D sequence, and I got every T1 plane I would want.
Yeah.
I mean,
Okay.
that's what I would do.
And who would go against you?
Right.
Oh, a lot of people,
Name them.
Yes, we will find them.
The other thing you've got to really be careful of is if you're not doing very many slices, people, especially GE people, are really bad about this. Growing up, when you were sitting there scanning on a GE, watch somebody scanning on a GE. They got the mouse and they're just clicking around. They're just clicking.
Okay.
What are you doing? They're like, I don't know why they do that, but they do that. Just click. But anyway, but there's a tendency, regardless of who you're scanning, regardless of what you're scanning on, there's a tendency to use as short a TR as you possibly can for the number of slices.
Oh,
Yeah.
right.
Yes.
That's not good. If you want bright fluid image, you really don't want a TR less than about 3,500 milliseconds.
Right.
And I don't like what's it called, fast recovery, or other people have different. Restore, where you have an extra 180 at the end to drive longitudinal back up. That technique was actually designed years ago to be used on low field, because you couldn't get scan times and try to get brighter fluid. But it makes fluid brighter, but it don't make it T2 weighted.
Right.
And so I've seen lesions missed in cervical spines by that. I want bright fluid images. I want a TR of 3,500 and higher. And if I'm looking for a cord lesion, subtle cord lesions, sagittal stir.
Would you do a diffusion on a pediatric, like a neonate, a younger?
You might, but it depends on what they're looking for.
Yeah,
okay.
exactly.
But that's why we do that pre-scan first.
Well,
Yeah.
if you don't need it, don't do it. Okay.
Yeah.
I mean, there's no reason to do it.
Right.
But there are stroke mimics, right? There are things that you can have, pathologies that'll mimic a stroke. And so sometimes you might have to work that out. But yeah, there's easily reasons. So I'll tell you my granddaughter, a couple of years ago, she's 12 now, so a couple of years ago, was being worked up for migraines. And so they go through all the things to try to figure out, see what can trigger it. It turns out getting hot and stuff seems to trigger it. But anyway, so of course they do an MRI because they want to see it, right? And lo and behold, she's got a subarachnoid cyst. Okay, turns out
incidental.
Pediatrics, it's not uncommon.
Nope.
Totally
pineal. Yeah.
It's a totally incidental finding. Okay, and they did a diffusion because you do a diffusion, it's a cyst. It's It's a cyst.
Proof positive.
Now, unfortunately, they wanted to try to do contrast on her because they wanted to complete. I'm not going, oh, right. My wife is going, now don't interfere. I'm thinking, it's a cyst.
Sucks when you know too much, right?
It's a freaking cyst.
Ignorance is bliss sometimes.
Yeah, I know. Anyway, so the contrast part didn't go well. But, anyway, I feel bad about it.
It's your wheelhouse. If ever there was a time to speak up, right?
Yeah, and I feel bad about it because I let other people tell me to not speak up. But you know, of course, naturally now following it up going forward, they're not going to give contrast because it's a cyst.
Right.
But yeah, so yeah, we
Right.
do it. Now she's, like I said, she's older, but yeah, there's reasons to do that because epidermoid cyst and stuff like that, you may have to differentiate with it. So diffusion may be done.
Awesome.
I do think that we would be doing a disservice if we didn't at least address like developmentally challenged pediatric imaging. And so with that, you kind of maybe treat it differently. Do you have experience with that?
Yes and no. So treat it differently, yes and no. Mock scanners, right, are a blessing. And you know, being able to bring a child in beforehand, do some practice runs on a mock scanner, they really look like scanners now, right? In the old days, it was just a plywood or something like that. And we're like, okay, pretend you're
Pretend this is a scanner.
Right, yeah. And, you know, I know that there are sites who can't afford that, and so they've gone with just tunnels and stuff and made it look like that. But there's the group called Child Life Services, and they have such fabulous distraction techniques, you know, and so at least at our site, we have the walls are painted astronauts, and so we have pictures of the bear astronaut or the tiger astronaut, depending on what room you're going into. We definitely say, let's go in and let's start looking for the tiger, like find the tiger, so that they're looking away from the scanner and aren't necessarily focusing on that. So yeah, you know, they're nervous just the same, but you just need to bring it to their level and get them through as best you can. Oh,
let me bring something up on this line. There is a company. The radiologist, interventional radiologist, started this. It's called Comfort Talk. Dr. Elvira Lang. I know, actually attended several sessions at some of the medical centers where they've done this for MRI. It's essentially a low-level for MRI, kind of low-level hypnosis relaxation type technique. I've had it work. I've done it with adults, and it works like a charm.
What?
I mean, I had this stocky guy who was not going to undergo a cervical spine. So give me just a few minutes, and he was asleep by the time he came out. But it's not that my voice would put anybody to sleep, but you know, it's just
Gotta be cheaper than anesthesia.
just, just techniques the way it's just the techniques the way you do it. But it works with children as well.
Yes.
And there's a book that she has written. It's not a very thick book, paperback, or you can get it Kindle. It's called Patient Sedation Without Medication. And you can get it on Amazon. And it's a very interesting read, but you know, discusses, you know, relaxation type techniques, and I think that's worth a look.
Sure.
In fact, I usually recommend, you know, when talking about claustrophobia or anxiety, I really recommend sites look at buying that book and just pass it around to everybody to read it. It's a very short, you know, it's not long book.
Yeah,
but
awesome.
Very
Good
interesting
plug.
read. Very interesting.
Anything that rhymes, I'm sold.
Yeah.
Well, I mean, like I said, I did pediatric imaging. This was years ago, but I did it for a few years, and I really enjoyed it. It was kind of fun, you know. But it was, I mean, obviously there were sad moments,
Right.
but you almost have to detach yourself from that.
Yeah.
One thing I always did I thought was fun is like if a patient was between a certain age, let's just say 5 and 10, I would say, "Have you ever played freeze tag?" Yeah, like, well, freeze, you're it.
yeah, yeah.
Please, you're it for 20 minutes.
But it's a real love-hate, right?
Yeah,
You either
absolutely.
really like it or you really don't like it.
Yeah, I don't think I could do it.
No.
I just don't think I could do it.
You know, as I get older and being a father now, I could see why it's very hard for a lot of people.
I couldn't do it. You know, it's kind of interesting though when one of the things we didn't talk about specific, but one of the things they use for deep sedation is propofol.
Yeah.
Okay. And in fact, it's very common. It's not uncommon. It's a great drug. I mean, it puts them out and they wake up really quick. When I had a little surgery done and they were debating whether to intubate me or not, it was going to be a short surgery. And so we were trying to kind of turn my neck because there was a spot behind my back of my ear on the other side. But anyway, I, you know, went to sleep. And when I woke up within 10 minutes, less than 10 minutes, I was good to go.
Wow.
I no
With
hangover,
propofol?
no nothing.
Did it burn going in?
I was asleep. They put me to sleep before they
Oh, really?
they put me under before they did that. Or they may have given me, and this is interesting about drug, Ativan. Now, Ativan will make you real chill, but Ativan, and you hear what's going on, and you know all this kind of stuff, but Ativan has a amnesic effect, and the reason they use it for pre-surgical sedation is that when the patient wakes up, they don't remember anything about the pre-surgical prep.
Yep.
And it gets them chill, but they don't remember it. Right. And that's why you got to be careful using that in MRI as a sedative for patients, because you give them this drug and then you do safety screening and they don't remember anything. It can be like problematic, really problematic. But anyway, so some parents, I just remember that back in the day, right, after Michael Jackson, because he basically overdosed on propofol. Right. Parents would go, "Isn't that what Michael Jackson had?" They go, "Well, we're okay. We'll be okay." I mean, he may wake up, grab his crotch, and moonwalk for 10, 15 minutes, but other than that, it'll pass.
Well, I did have, and we may or may not keep this in, but I did have a personal experience with an overdose with propofol on a pediatric patient. We were doing a ped sedation with propofol, which, by the way, because you do those, right? Do you do them with propofol? And you look for that big yawn.
Yep.
That's right when. But so we had a pediatric patient. I'm going to make up a number. I guess they would have been less than a year old. But the nurse who programmed the MR pump to bolus the propofol did the wrong dosage and gave them an adult dosage, and that was a scary moment.
Yeah,
that is.
So yeah, and I say as a parent, I want to be in the room, but as a parent, I wouldn't have known whether or not you're overdosing my child. So it's
well, one of the other things, interestingly, have nothing to do with pediatrics per se, but I learned this here recently. So the one big pump that we have now, what's the Iradimed pump? There's really not anything out there. Okay. Yeah. Talking with some nursing personnel, their problem they have with it, apparently the controls on the Iradimed are exact opposite of the controls on the standard pump.
Right.
So there's a learning curve for it, and if the nurse doesn't have frequent experience with it, that's what their concern was. It'd be problematic. So my recommendation to this particular site was get a core team where there's 4 or 5 nurses that use this pump, so that
get it in service as well.
Right, and then that way it's easier for them to remember it. But it's.
Do you think that should be a part of level 2 training?
No, it's no. Well, if the nurse is an MRI nurse, then she's going to remember how to use it.
That's
so
true.
then it's not going to be a problem.
Yeah. Right.
The problem these nurses were saying was there are hundreds of nurses, so if everybody does it, it may be once a year that they see an MRI pump, that was the problem. That was the real problem. It's not that it's difficult to learn to use. Just keep in mind when you're talking about a nurse from a floor, depending on their exposure to that pump, it can be. Controls are in a different location.
Well, with like everything, there's a learning curve. So yeah, I don't know. Katie, do you think we're missing anything? Pediatric imaging?
Yeah.
So I guess, Nancy, we had to ask you the question we ask everybody.
Oh no!
Dun, dun, dun. But we've already asked you. But at the end of every episode, and we didn't prepare you, so it's kind of put on the spot. But what would you say has been the most fulfilling or satisfying moment of your healthcare career?
Not including this
all
podcast.
40 years. Yeah.
Oh, wow. This is going to sound so lame. It's the progression of MR. Bill and I were talking. We have it so easy because we learned MRI when the button was, minimum TE and minimum TR. We didn't even have a choice of things at 1.7. And we only had spin echo and IR. And so as each software release came out, we only had to learn 1 or 2 new things.
Yeah.
From full field view to
baby steps.
Yeah. And so I'm just gobsmacked at technologists, radiographers coming in now, and they have to take all this on. And and they go, "Wow, you know so much." And I'm like, "No, it was easy for us." So
learning to swim by going in the the kiddie pool, waiting, learn to swim, and now they're just thrown in the deep end with ankle weights.
Right. We had it so easy.
Mm-hmm.
Right.
Yeah, awesome. That's a great answer. Reggie, are we missing anything?
No, I definitely want to give a big shout out to, of course, the NEATCap Medical. Please, definitely, if you guys are doing any pediatric imaging, at least go check out their website. go see what they're doing, because that technology is definitely it's a difference maker, right? And we want to protect these children.
Yes.
And hopefully they come out with an adult version, for sure.
For me.
But no, you could
That would
definitely
be a gag.
But check them out at NEATCapMedical.com. All right, and there'll be a link in the description for sure.
Yeah, we want to say hi to Kristen again, and my apologies to Dr. Howard Brown. I think that's it, right, Reggie?
Yeah, thanks for subscribing. Thanks for watching. Thanks for, coming back week after week. Whenever we release an episode, you guys are always there. So we appreciate that. Zone 3 Podcast. We're out. Good.
See ya.
I said your part, my bad.
And
You hesitated?
I was like, just go for
What
it.
do I do now?
I was.